I'm going to talk about early detection of kidney disease in the cat. And the cat obviously is an important species to consider kidney disease in because of the very high prevalence that we see. We talk about kidney disease, chronic kidney disease, as though it's a single disease syndrome, but in fact it's quite heterogeneous. And we'll see cats with very stable chronic kidney disease, those with very progressive kidney disease, and there are lots of different causes. And the challenge really is not just to identify the kidney disease at an early stage, but then to use that ability to really find out what's causing the damage to the kidney. Because if we could halt that process, that primary disease process, that's our best chance, really, at preserving kidney function as much as possible for the rest of the cat's life. So what we need to do is to determine the cats that are at most risk of chronic kidney disease so that we can screen a high-risk population, and then to find early markers that will give us the confidence to investigate further and identify what is the primary disease problem. And we're a long way from that at the moment. And so what I'm going to do is to talk about, first of all, the epidemiological risk factors, and then where we're at in looking at those cats that are at high risk and identifying their kidney function. I find this diagram quite useful when I'm teaching about kidney disease. It has the iris staging system on it, but it uses terminology that's common in many of the textbooks as well, which is very imprecise. And it explains what we mean about the different stages of kidney disease. Normal kidney function with a full complement of nephrons will be subject to extrinsic damage from a primary disease process. And that will give rise to what some people would call early kidney disease, where there's no biochemical evidence. There's no change in the plasma creatinine concentration, for example. And that would be stage 1. But there has to be something that tells you that that cat has some form of kidney damage or some abnormality to put it into stage 1. And that might be because it's persistently proteinuric, for example. With continuous loss of functioning nephrons, the stage of kidney disease progresses, and it progresses to a point at which the remaining functioning nephrons start to do some adaptation to try and continue to excrete the waste products effectively from the body and to control homeostasis of phosphate, for example, which I'm going to talk about in more detail this afternoon. So those maladaptive responses, such as glomerular hypertension, and the hypertrophy of the remaining functioning nephrons may in themselves be damaging to the kidney. And that's why actually waiting until these later stages of kidney disease makes it much more difficult to treat, because the disease then is self-perpetuating. But we must also recognize that there may well be continued extrinsic damage, urinary tract infections, for example, toxic ingestion of substances, for example. So stage 2 may still be difficult to detect biochemically, but then starts to become detectable in the later parts of stage 2. When we move into stage 3, those processes are well established, and the kidney nephrons that are remaining, which are very few in number by this point in time, are, if you like, damaging themselves because of those maladaptive processes. We've got hyperparathyroidism going on. We may have hypokalemia because the kidney is not able to conserve potassium. It actually has adapted to excrete too much potassium by that point in time. And And again, those extrinsic damage mechanisms, such as systemic hypertension, which may be a complication of loss of functioning nephrons, continue within the stage 3. And this is the point at which the cat will be showing many clinical signs, and those clinical signs of the uremic syndrome will continue to worsen as it moves into stage 4, and the animal might once have been described as having moderate to severe kidney failure, and reaches the end stage where this is no longer compatible with life, and that would be later stage 4. There are stage 4 cats that are eating, that are able to exist. It depends how rapidly the animal has moved between those stages. So with that as an introduction, I want to move on to talk about how common is azotemic chronic kidney disease. So that would be in that stage 2, stage 3 situation, moving into the stage 4. So we looked at this in a prospective study in two different time points, 2 different times of recruiting cats prospectively, screening them for their renal health, and then following them over time. And we've published 2 different studies, and the prevalence was different in the 2 studies. We looked at 343 cats in one study, and were able to get long-term follow-up on 195 cats. The problem with this type of research is that cats do tend to get other diseases of older age, and it's obviously the old age category that we're looking at, so these are cats of 10 years or older. And 30 of the cats that we followed developed hyperthyroidism. Now, hyperthyroidism really makes it very difficult then to assess what their kidney function is doing over time, because hyperthyroidism itself causes hyperfiltration, it causes proteinuria, it actually causes hyperparathyroidism as well, and disturbances to phosphate and calcium balance. So it really complicates the issues of understanding what's going on with kidney function. With those, excluding those hyperthyroid cats, we had 148 cats that remained in this study and completed full lifestyle questionnaires, and 27 of those 148 developed azotemic chronic kidney disease over the subsequent 12 to 18 months. And so that incident of chronic kidney disease in that particular study was 18%. We did a very similar study a few years before this, and we had 95 cats, 29 of which became azotemic within 12 months. And that's a prevalence of 30.5%. And the main difference between these 2 studies was the age range of cats that we recruited to them. We recruited them through our primary care practice in central London, and the first study was done between 2002 and 2005, and the second study between 2005 and 2009. And I think what we'd done is we'd actually got the older cats into the first study, and the median age differed by about a year between those 2 studies. So from the lifestyle questionnaires that we did in the second study, we were able to look at what are some of the risk factors for the development of azotemic chronic kidney disease. And that was collected on these 148 cats. And of course, age was one of the factors that influenced whether they developed chronic kidney disease or not. The 2 other factors that came out as highly statistically significant in this study were frequency of vaccination. Those cats that were vaccinated on an annual basis had kidney disease, azotemic kidney disease, more commonly than those that were vaccinated infrequently, and the severity of their dental disease. So this is the output from the multivariate analysis that looked at those factors. And just to take you through, because I think looking at these papers can be quite confusing, what this figure here, the hazard ratio, indicates is relative to the reference group at how much greater risk is the group that we're under consideration. So the reference group for vaccination were those cats that had had no vaccinations or had only been occasionally vaccinated. So maybe they'd had a primary course and a booster dose, but no subsequent vaccinations. And remember, we're dealing with people presenting to a charity clinic, so our population of cats would have a much higher number of cats that had had infrequent vaccination than a general practice situation. Because this charity clinic doesn't offer routine vaccination as one of the things that it provides to the owners. So here we see that the cats that had frequent vaccination were 5.6 or 5.7 times more likely to be to develop azotemic chronic kidney disease over the subsequent 12 months. Here is the degree of uncertainty, the 95% confidence limits on that hazard ratio. If that lower or upper one crosses 1, so if the difference between those, so if the lower one is below 1 in this case because it's an increased hazard, it's not likely to be, it's not statistically significant. And that's why cats with mild dental disease, although they appear to be at 2 times higher risk, it's not statistically significant because the lower confidence limit is below 1. Whereas the moderate and the severe dental disease patients are at much higher risk, but look at how wide the 95% confidence limits is. It could be as low as 4 times or as high as nearly 300 times at increased risk. And the reason for that is because there's low numbers in that group compared to the other groups. And you'll see that when I look at the survival curves, where the outcome is development of, or the event is the development of azotemia, which is obviously the first time that we identified that in a cat, and that will depend on how frequently we're screening those cats in the follow-up period. So here is the vaccination studies. So those cats that were frequently vaccinated, we had 26 of those, and we had 78 that were only occasionally vaccinated. And that is a quite unusual population because we were recruiting from the charity clinics. And you should take that into account when you're looking at these data and translating them to your clinical practice. With the dental disease, we only had 11 cats that were classified as having severe dental disease in this study. And that's why those confidence limits are very wide on that hazard ratio. Whereas we had reasonable numbers of cats with mild dental disease, but that didn't reach statistical significance in terms of the risk for developing azotemic chronic kidney disease. So this study shows us that there's something there, and probably we need to follow it up with more investigations and longer studies of more cats, larger populations of cats, to see whether it translates there. But more importantly, these are associations, not causes of chronic kidney disease. So we shouldn't stop vaccinating cats, for sure, because we're reducing the risk of infectious disease with that strategy. We should maybe consider how frequently vaccinate cats, but we should try and understand why there is that relationship. It could be that those cats that are coming in for frequent vaccination are having more follow-up and more screening. But in our studies, we were inviting them to be screened at equal periods of time, so that doesn't appear to be the explanation in our studies. Older cats that are presenting for dental disease, we certainly should be screening those for chronic kidney disease. But why are they at greater risk? What is it about dental disease that increases the risk of chronic kidney disease? If we understood that, then we might be understanding more about the primary causes of chronic kidney disease in cats. But what this information does is it helps you to target the population of cats in your clinics that you should be screening, and really helps you to be doing those screening tests on cats that have a higher risk of chronic kidney disease. So having talked about that epidemiology, and we haven't got enough epidemiological data about chronic kidney disease in cats to understand what the risk factors are and which are modifiable to help us to protect cats from chronic kidney disease. what I want to spend the rest of the lecture talking about is assessment of renal function. And I'm going to go through this plan, assessing renal function based on glomerular filtration rate, assessing tubular and glomerular damage and dysfunction, and then looking at the extrarenal consequences of reducing kidney function, because all of those tests can form the basis of making an earlier diagnosis of chronic kidney disease. I'm going to start off with glomerular filtration rate, which is the gold standard for assessing kidney function, because the global glomerular filtration rate is related to the number of functioning nephrons in the kidney. Remember, though, that as the number of functioning nephrons reduces, those that remain tend to hyperfiltrate. So that will change the relationship and make it less sensitive as we reduce numbers of functioning nephrons. The gold standard for measuring glomerular filtration rate is urinary clearance of inulin, so infusing a marker called inulin, which has a molecular weight of around 5,000, and the only way that that is excreted from the body is through the kidneys, we think. But if you're measuring its appearance in the urine, then you can calculate the filtration rate. But that's really only practical in a research setting, and the methods that are used in the clinic are to look at plasma clearance methods. And actually, it turns out that inulin has a proportion of the dose excreted in the bile, and so is not as good a marker for plasma clearance methods as some of the others. And the one that we actually use is iahexol. Iahexol fits these criteria. It's distributed only in the extracellular fluid, it's freely filtered, it's not reabsorbed, and it's not secreted into tubular fluid. Therefore, the rate of disappearance of this marker from the plasma is proportional to the glomerular filtration rate. And we do have an accurate and reproducible method for measuring the plasma concentrations of inulin. And there is research that has worked out a limited sampling method so that we don't have to blood sample the cat on 9 or 10 different occasions in order to calculate the glomerular filtration rate. So this is the theory behind looking at plasma clearance. And what most people do is to take a 2-hour, a 3-hour, and a 4-hour sample and measure the slope of the rate of change of iahexol in the plasma. And in fact, you get a computer to do that for you and calculate the glomerular filtration rate from that. That is extrapolating the curve back to an original concentration here, but what it actually misses out is this portion of the area under the curve. So the classical clearance method is the dose divided by the area under the curve equals the clearance of the substance from the plasma. And what that area that's missing represents is negligible in a cat that has established azotemic kidney disease, because that's the redistribution phase when you inject the iahexol intravenously. So it's negligible in a cat that has chronic kidney disease, but it represents about 12 to 20% of the clearance for a cat that has borderline kidney function. And so it is actually quite important that you do take that into account when you're calculating the glomerular filtration rate. So there needs to be a slope-corrected method for calculating glomerular filtration rate. And that's what Natalie Finch did with us, was to derive a glomerular filtration rate based on doing this study with multiple samples and doing the classical measuring the area under the curve, but then doing a multi-compartment analysis and a slope-intercept analysis correcting for that missing area. If you didn't correct for that missing area and you just took the slope, then the glomerular filtration rate came out at 2.4 mils per minute per kilogram, which is about 12% higher in these cats than the actual glomerular filtration rate calculated by a multi-sample method. one of the problems with Iahexol is having a method to measure it. And the methods that are available through human hospitals are sometimes difficult to access. At the Royal Veterinary College, we do offer a service of measuring glomerular filtration rate using Iahexol, and we do that in partnership with a company that have a high-performance capillary electrophoresis method, which we have validated in parallel to HPLC and other methods that are well validated for measuring glomerular filtration rate. And so you can do this on 3 blood samples. That's still a bit of a tall order in a cat that isn't particularly keen on having any blood taken. And so one of the things that Natalie also went on to do was to work out a way of doing that from a single sample, which is more practical but less accurate. But most people won't measure glomerular filtration rate and will use surrogate markers of glomerular filtration rate, such as creatinine and SDMA. I'm going to talk about those now for the next 5 minutes. Creatinine is a breakdown product from muscle, and creatine phosphate is where the energy stores in muscle are kept. And so the amount of creatinine that's produced is dependent on your muscle mass. There is a little bit of tubular secretion of creatinine that occurs, and actually with some pet food diets there is the ability of creatinine to be liberated from the food, and so to have an increase following dietary intake. And then there are some issues about specificity of assays. So the enzymatic assay is much more specific for creatinine and doesn't measure other non-creatinine chromogens, whereas the picric acid assay will measure non-creatinine chromogens. And so these are some of the technical things that you need to be aware of, but many people are used to using creatinine, use the same laboratory, and can tell whether creatinine is changing over time, which is a good indicator of deterioration of kidney function, provided the animal isn't losing weight at the same time and losing muscle mass. But because of the problems with creatinine, IDEX have launched a method for measuring symmetric dimethylarginine. And symmetric dimethylarginine is a product of cell metabolism, of protein catabolism, where the proteins have been methylated at the arginine residue of those proteins. And it produces this compound, symmetric dimethylarginine, at a stable rate, which is much less affected by body mass, lean body mass, and is therefore less affected by many of the factors that influence creatinine. More than 90% of SDMA is renally excreted, and it makes it a good marker for glomerular filtration rate. It's important to recognize the relationship between any plasma marker of glomerular filtration rate and its plasma concentration is an exponential relationship. It's a log relationship because as the concentration increases, the rate of excretion increases because it's a first-order reaction. And so this is what you see with creatinine when we actually measure creatinine and glomerular filtration rate and plot it out. We do get a highly statistically significant relationship. The R-squared value is 0.6. So there are other factors that are influencing this relationship, such as body mass. And it would be good if we could correct those factors and make the relationship even better. But the same relationship will appear between SDMA and glomerular filtration rate. And if you look at glomerular filtration rate against 1 over creatinine, which is a way of making this linear, then you see that the R-squared value in these 10 cats that were selected to have a range of glomerular filtration rates is virtually identical to the R-squared value for the same relationship between SDMA and glomerular filtration rate. So the relationship is the same. These are filtration markers because GFR is the one thing that is really influencing how rapidly they're cleared from the plasma. And as long as their rate of production is relatively similar between animals, then you will get a similar plasma concentration for a given GFR. So is it possible to correct creatinine to make it a better reflection of glomerular filtration rate? Well, Natalie Finch in her PhD studies tried very hard to do this and looked at all sorts of morphometric measurements to see if they would influence the relationship between creatinine and glomerular filtration rate such that we could produce a better relationship, correct the creatinine to better reflect the glomerular filtration rate. And I guess, to cut a long story short, the answer was we failed to find any parameters that were really very helpful in correcting that creatinine to better reflect glomerular filtration rate. We managed to improve the R-squared value a little bit, but not significantly, such that I would say this is something you must be doing in your general practice to correct that creatinine. So that was a little disappointing because that's something that's done in human medicine, and there are well-established equations to take your creatinine and to correct it because of your physiological characteristics to make it better reflect your glomerular filtration rate. So the next question I want to try and answer is SDMA more sensitive than creatinine in diagnosing chronic kidney disease at an earlier stage? And I'm sure many of you will think, well, that's been proven, hasn't it? Because IDEX tell you that that's the case, and they've certainly done a study that does suggest that that is the case, and I think I would agree that SDMA is more sensitive. I think the question that still needs to be answered is SDMA specific enough? And are the sensitive levels of SDMA, which would be between 15 and 20 micrograms per deciliter, are those specific enough for you to use to say this cat has definitely got chronic kidney disease? And perhaps that's a question that still needs to be answered. So the study that was done was a retrospective longitudinal study. It was one of convenience because the cat colony that was used for this study had been routinely sampling cats over their lifetime and had samples stored in the freezer so that their SDMA concentrations could be measured in those samples. And they had 21 cats that developed azotemic chronic kidney disease, or I should say they had 21 cats that developed kidney disease over the period where they could go back and look at their SDMA and compare that to creatinine. Chronic kidney disease in 15 of those 21 cats was because they had persistent azotemia. 2 cats had calcium oxalate nephroliths, and they said, well, that's equivalent to chronic kidney disease. And 4 cats had a reduction in their GFRs of 30% or more. And that's comparing the GFR values to normal healthy cats, which they selected from their group, an equivalent number of normal healthy cats that had been followed for more than 6 months and had normal glomerular filtration rates. Well, they defined normal from that group of cats, a normal serum creatinine and a urine-specific gravity of over 1040, 3 measurements that were used for the GFR in each of these cats, and that gave a 25th percentile, a 2.5 percentile for the lower limit of the GFR of 1.34 mils per kilogram per minute. And they took that as being the lower limit of normality, and any of the cats that had chronic kidney disease diagnosed based on GFR were below that 1.34 mils per kilogram per minute. With what the graphic is showing is taken from the paper, and it's plotting serum creatinine against serum SDMA, and they had no false positives, so they had no cats that had elevated serum creatinine without an elevation in SDMA. Serum SDMA increased when serum creatinine was within the reference range, and they took the reference ranges up to 2.1 milligrams per deciliter for creatinine. And so that this is the another figure that's taken from the paper showing how creatinine rose at a later time point to SDMA in this individual cat. So these are individual sample points for this cat, and in the blue is creatinine and in the red is SDMA. And you can see SDMA starts to go up and goes over the reference range, and that's 17 months prior to serum creatinine going up and going above the reference range in this cat. So in the paper, they say that serum SDMA increased before creatinine in actually 11 of the 21 cats. In 4 cats, there wasn't bank serum available that became azotemic, so they couldn't actually tell the point at which SDMA increased above the reference range. And 4 cats never had a serum creatinine above 2.1 milligrams per deciliter, so they took the time at which their creatinine was diagnosed of chronic kidney disease as the time of death. And they then reported the 2 cats with oxalate stones as having chronic kidney disease. They were never azotemic. And again, so it was their follow-up time that was taken as the time from SDMA being elevated to as the time before their creatinine was elevated. And in the paper, they quote a value based on 17 cats as being 17 months, a median value, and 1.5 to 48 months. So the conclusion from this paper does suggest that SDMA is more sensitive than creatinine in detecting early-stage chronic kidney disease. I think the definition of a reduced GFR below 1.34 mils per minute per kilogram may not translate into the general population of cats, because these cats are a colony of cats. They're all eating the same food. They're treated in exactly the same way. And GFR will be influenced by a number of these factors, genetic factors as well. The study, I would say, is not well designed to assess specificity, because in general practice, what you want to know is those cats that you suspect of having chronic kidney disease, how common is a false positive, which would be the definition of specificity. If you have false positives, then you want to be able to categorize as many cats as possible that are negative. And so SDMA needs to be looked at in those cats that you suspect as having chronic kidney disease, but you're not sure about them, in the screening population. So there's likely to be more false positives seen in a wider population. And at the moment, IDEX do now recommend monitoring cats with SDMA between 15 and 19 micrograms per deciliter, unless other data confirms that they have chronic kidney disease. And then the question that really remains to me is how to manage these cats at this early stage. Because actually what we want to know about the kidney disease is this likely to be rapidly progressing, or is this a very slow decline in glomerular filtration rate over time? Is it something that we can intervene because we understand what the underlying cause is and we can treat that disease? Or is it something that we'll monitor because the cat will actually have its chronic kidney disease and it won't die of it, it won't actually develop clinical signs over time, it will have some other problem that leads to its death, ultimately. And in our experience, about 50% of cats that we see with chronic kidney disease are so slowly progressing they stay in stage 2, and the remainder progress and develop really marked uremic signs and need to be euthanized because of their chronic kidney disease. So it would be important to differentiate between those two groups. The next section is I'm going to talk about glomerular and tubular damage and dysfunction, and really looking at urine samples to see if we can detect that damage. So proteinuria, I think the research that we and others have done over the last 20 years has redefined proteinuria. When we first started working on this, a urine protein to creatinine ratio of needed to be above 1 before it was actually reported as abnormal. In the cat, now we would say that urine protein to creatinine above 0.2 is suspicious, and definitely above 0.4 is abnormal. And many of our studies show that a UPC of above 0.2 is a significant risk factor for development of azotemic chronic kidney disease, and actually those cats are more likely to be progressive. So proteinuria is important because in human medicine it is an independent risk factor for kidney disease. Albumin leaking across the glomerulus is potentially an indicator that that hyperfiltration process is occurring. Tests that detect albuminuria are available, although they haven't had a very good track record because of their lack of specificity. So albuminuria, proteinuria is an indicator of renal dysfunction, either glomerular or tubular dysfunction, because remember that normally some albumin leaks across the glomerulus, but it's returned by tubular reabsorption of that protein. So transient albuminuria is common, and it can be an indication of other systemic diseases, chronic inflammation and the like. So you need to really demonstrate that it is persistent. And one thing I would say is that these sticks are absolutely useless for the cat. They always come up as 1+ positive, and that could mean that the UPC is normal, below 0.2, or it could actually be that it's significantly proteinuric. So as a screening test, just ignore the protein stick on this test unless it's negative, which it very rarely is for a cat. Some of the data that demonstrates that proteinuria is an important risk factor in the cat, my clock's gone to 0, but we were 10 minutes starting, so I think I've got 10 minutes left. It is this study which Roseanne Jepson published in 2009. And what this study is looking at is both urine protein to creatinine ratio and urine albumin to creatinine ratio in the 95 cats that I talked about previously, but divided at initial screening on the knowledge that at 12 months, 30% of them became azotemic. And you can see on this log scale, there is a significant difference between UPC and urine albumin to creatinine ratio, but there's a lot of overlap. And that's reflected in the sensitivity and specificity of these tests. So if we take, we can produce a screening value that picks out cats that have the disease, 82%, that will go on to become azotemic, 82% of these, but it's not very specific. So we get lots of false positives if we do that. So the specificity is compromised if you choose very sensitive testing, and that would be to have either creatinine above 1.6 or UPC above 0.2. If you have to have both of those, you improve the specificity to 80%, but you lose sensitivity. So this is on a one-off sample, but it's based on just those two parameters, which came out as statistically significant in this classical study. At the end, I'll describe some more advanced studies looking at machine learning and longitudinal data, which may improve on these screening tests. Looking at proteins in the urine can also tell you something about tubular function, particularly if you look at low molecular weight proteins that are easily filtered and then reclaimed by the proximal tubules. Things like beta-2 microglobulin, alpha-1 microglobulin, retinal binding protein. And those come up very early in human disease in diabetic nephropathy, where there is a hyperfiltration that's driven by the hyperglycemia and the glycosylation of proteins in the basement membrane of the glomerulus. In addition, there are proteins that are released from the tubular cells that indicate damage. And those are, and the glomerular cells, in fact, NGAL, cystatin B, clusterin, NAG, gamma-GT, and others. And they've all been looked at in small studies, and they all look as though they show something. Actually, when you go back and you look at their predictive value relative to urine protein to creatinine ratio, often they don't add anything. But what I think we need is to look at a whole profile of these, a whole panel of these, in large studies, longitudinal studies, to see what they're predicting. And it should be in the future that transcriptomics of cells that are released into the urine would tell us something about the disease process that's going on in the kidney and whether it's active at the moment, at that moment in time. So I'm sure the future will give us new diagnostics that will tell us about activity of disease within the kidney and help us to target those animals that really need treatment. I'm going to skip over those two slides. They were about looking at fragments of proteins in the urine using CellD as a method of fingerprinting the protein fragments. But just to conclude on this section, single urinary markers can be used to differentiate two populations of cats at risk of azotemia, low risk and high risk. Individual variability, though, and other disease states will influence the sensitivity and specificity of those tests. I think urinary proteomics is probably the future. Looking at multiple markers with multiplexed assays will be the way forward to really tell us about the individual cat. And I think there's a need for longitudinal studies with larger numbers of cats. And that is really the thing that's holding back the development of these tests, because it is a considerable investment in these studies. The final section in the last 5 minutes is just to talk about bone mineral disturbances. And I'll talk a lot more about this this afternoon, so I will skip over this at this point in time. But as glomerular filtration rate falls, the body's ability to get rid of phosphate is reduced. So if phosphate intake continues at the same level, so you're feeding the same amount of phosphate per day, phosphate will tend to accumulate in the body, and the body's response is to secrete a hormone called FGF23 to try and unload that phosphate. So FGF23 inhibits phosphate absorption and stimulates phosphate excretion from the body. And it does that without bringing more phosphate out of bone. Once this adaptation becomes maladaptive, then it brings PTH up, and PTH is bringing phosphate out of bone as well, which compounds the problem. But the earliest change that we see is in this hormone called FGF23. And here are some distribution curves, serum distribution curves for FGF23 in a group of normal cats and a group of cats that were fed a standard diet in a colony. And you can see the distribution is quite different. And this tail on this distribution suggests that actually a proportion of the normal cats are phosphate overloaded. And when we look at FGF23 in a prospective study, as a predictor of the onset of azotemia, we had 62 cats in this study. The first group, these cats remained completely normal over the 12-month follow-up period. These cats had borderline renal dysfunction, and these cats became azotemic. And you can see that the FGF23 increases in proportion and between those three groups, and is significantly different from the group that remains completely normal between the two groups. And look at the distribution here. Most of these cats, in fact all of these cats, had apart from one, had an FGF23 below 300 picograms per mil. If we then look at cats that are diagnosed based on SDMA as having early stage chronic kidney disease, and SDMA above 14, then we see how many of these have FGF23 above 300. Well, about 62% of those. And that would suggest to me that those cats are overloaded with phosphate and should benefit from being phosphate restricted. So now, perhaps we're moving towards a situation where we can target some treatment on those cats that have an early diagnosis of chronic kidney disease. The cats that are below 300 probably don't benefit from having phosphate restriction at that stage. And you don't have anything to monitor as to whether that phosphate restriction is having an effect. We would expect FGF23 to reduce in those cats that were phosphate overloaded if you restrict their dietary phosphate intake. Notice in these cats, the FGF23 is different, but the plasma phosphate is no different between the two groups because it's intracellular phosphate that builds up first in this overload problem in the chronic kidney disease patient, and then it spills out into plasma phosphate increasing at the later stages of their chronic kidney disease, stage 3 probably, and beyond. So FGF23 in early stage kidney disease determines those cats that would benefit from phosphate restriction, perhaps, and there's a question mark against that because we haven't done the studies to really demonstrate that. We need prospective studies. Enrolling cats that are at higher risk of developing azotemia would then be helpful. So can we really identify those cats very accurately that are at higher risk of developing azotemia? Well, one of the studies that is under review at the moment that has come out of work from Waltham and Royal Canin is to develop an algorithm using multiple longitudinal data from cats that are screened routinely using our health screens. And that model is based on 4 different parameters and has a specificity of predicting the onset of chronic kidney disease of 99%. Obviously, its sensitivity falls over time. And if we look at 2 years, 18 months prior to the onset of azotemic chronic kidney disease, we'll see that the specificity is around 50%. So what does that actually mean? Well, if you have 100 cats in your clinic that you screen for chronic kidney disease, and the pretest prevalence of azotemic chronic kidney disease occurring over the next 2 years or so is 15%, for example, that means that there are 85 cats that are true negatives in that population. And this test algorithm would actually identify 84 of those cats as being negative. 15 positive cats, this would identify 7 or 8 of those as being positive. That means that 91 out of the 100 cats will be correctly identified by this screening test, which isn't one test, but it's a combination of different laboratory tests looked at in cats and using an algorithm and machine learning to look at the changes over time in a large population of animals to predict what values should be used as cutoff values. So that's actually pretty good, I would think, especially as the consequence of getting this wrong just means that you're going to wait another year before you actually test that cat again for its chronic kidney disease, and you will still probably pick it up at an earlier stage with routine annual monitoring than would be the case if you weren't monitoring these cats. So, just to finally conclude then, early diagnosis of kidney disease, chronic kidney disease, is a goal. If we can identify ways of halting progression to azotemic kidney disease. And I would say actually differentiating progressive chronic kidney disease in stage 2 is also a goal for feline medicine. Currently, prediction is focused on markers of GFR, but actually I think we want to look more in the urinary markers to see whether we can distinguish active disease from stable disease using those urinary markers. Defining when there is active disease, I think using the urinary proteome, therefore, is very important. Looking at FGF23 may well help us to target specific dietary treatment in those cats that are becoming phosphate overloaded. And I didn't talk about indoxyl sulfate, but that's an interesting marker which I can talk to people about afterwards if you want. So just to then look at, if we have a reduced GFR indicated by serum creatinine above 1.6 or SDMA above 14, or even with our hexol clearance, if there's no evidence of active disease, I would suggest we would just be continuing to monitor that cat. Whereas if we have evidence of active disease, so urinary biomarkers, FGF23 increased, indoxyl sulfate increased, then that's active treatment, and we should be investigating active disease, and we should be investigating further, because we may well be able to identify something to treat specifically. Thank you very much for your attention. I'd just like to acknowledge the people who did all of the work, which are PhD students in my group that I talked about, and my academic colleagues, and to recognize that Waltham and Royal Canin have funded much of the work that I talked about today. Thank you very much.